If you have a good way of approaching it, anemia is incredibly simple. We're going to spend a total of 4 videos on anemia. This one, the overview, and then the subsequent micro, macro, and normocytic anemias that follow. It sounds like a lot of work, but it's really easy to get points on anemia. In this lecture, I want to start off by talking about symptomatology of anemia and then the overall workup picture, how you should approach anemia both on the boards and on the wards. Let's start off with the symptomatology. And I want to correlate a hemoglobin level with symptoms. A normal hemoglobin is greater than 13. And if you are greater than 10, it doesn't really matter what your cardiac reserve or what your underlying comorbidities are like. A hemoglobin greater than 10 is essentially always asymptomatic. As you begin to drop your hemoglobin, the symptoms worsen. And it's worth saying now, anemia presents with symptoms. The symptomatology of anemia is based on the severity, not the etiology. So as you begin to go a little lower, you start to develop malaise and fatigue. And this is the athlete who used to finish the entire hour-long game, who now can't quite finish the game. The person who was active, who couldn't be quite as active as they were before. Still, as the hemoglobin falls further, this is when they get dyspnea on exertion and pre-syncope. They're not just not able to finish the game, they can't make it across the field. And as they go even lower, this is when they begin to experience symptoms of death. MI, stroke, and high output heart failure. Now it is comfortable to associate a number with symptoms, but it's a lie. And it's a lie because the symptomatology is based on the severity, the acuity, and your cardiovascular reserve. That is to say, the lower the number, the worse the symptoms. The faster the change, the worse the symptoms. And the sicker you are at baseline, the worse the symptoms. Let's see what I mean by that last part. It has to do with the delivery of oxygen equation, which is equal to the cardiac output times the hemoglobin times the percent saturation. How many hemoglobins there are, how well saturated with oxygen they are, and how fast those hemoglobins are circulated around. If you take an advanced athlete, a marathon runner, their cardiac output at baseline is quite elevated. In fact, the resting heart rate may be near 40. They likely have good lungs, so they sat at 100%. If they suffer a small drop in their hemoglobin, this competitive athlete won't feel it. It takes a very large drop in hemoglobin for them to experience anything. And at that point, all they may experience is a compensatory increase in their heart rate to further increase their cardiac output. And so, not surprisingly, tachycardia is a symptom of anemia. But if you take instead the CHF, COPD patient who's having an MI right now, because of the congestive heart failure, their contractility is already compromised. Because of the COPD, their percent sat is already compromised. This patient may have a very small drop in hemoglobin and they may experience very severe symptoms. The idea is we're having stark contrast in the cardiac reserve. But still, other signs and symptoms exist which are dependent on the level. Once you get less than 8, this is when you begin to experience pallor, both of the skin and of the anterior rim. The anterior rim is the space under the eyelid. If you have no vessels in your anterior rim, you have a hemoglobin less than 8. So whereas some signs are reliable to a number, symptomatology is going to be based on the cardiac reserve. Also understanding that it's about calculus. It's the change in hemoglobin over the change in time. Large swings in the hemoglobin over a short amount of time make more symptoms. Slow changes over a long time, the body has a chance to adapt, and so you may even see people with hemoglobins of 2 and 3 who are walking around asymptomatic. This is the symptomatology. Let's talk about the diagnostic workup. So someone comes in with the signs and symptoms of anemia. You get a CBC or an H&H in order to confirm that they have anemia. Of course, if they don't have a decreased hemoglobin, they don't have anemia. And you stop. You look for something else. But if they do have anemia, the next thing you look at is the mean corpuscular volume, also included on the CBC. And I like this method because it tells you what to do next. And the MCV will tell you one of 3 things. This is like Goldilocks. It's either microcytic, too small, macrocytic, too big, or just right, normocytic. But before we get down into each of these categories, I wanted to teach you something else. Most microcytic anemias are production anemias. Most macrocytic anemias are production anemias. And of course, it would be too easy if it were something else. But normocytic anemia is usually destruction anemia with some exceptions. What do I mean by production and destruction? Well, all anemia is either from increased red blood cell turnover, this is a red blood cell exploding in hemolysis, or from a decreased production from the bone marrow. The way you separate that out is with a reticulocyte index. If it is a destruction anemia, red blood cells are dying or being hemorrhaged, the bone marrow will attempt to create more. So if the reticulocyte index is greater than 2%, it is likely to be a destruction anemia. If, on the other hand, the reticulocyte index is less than 2%, it is probably a production anemia. Now, even though the hemoglobin is low, the bone marrow cannot make any more, even though it should. So for the most part, microcytic anemias are production. They'll have a low reticulocyte index. Macrocytic anemias are production anemias. They'll have a low reticulocyte index. And the normocytic anemias are often destruction and will present with an elevated reticulocyte index. So the first thing you should do when you identify a low hemoglobin is look at the MCV and order reticulocyte index. All right, let's talk about microcytic anemia first. We have a whole lecture dedicated to it. But here are the highlights. When you have a microcytic anemia, the next step is a ferritin. If you have to pick one test, pick ferritin. But you get iron studies, which include iron, ferritin, TIBC, and a percent saturation. This alone allows you to make the diagnosis with laboratories between iron deficiency anemia, anemia of chronic inflammatory disease, thalassemia, and sideroblastic anemia. For the details of this, check out that lecture. Go to the opposite side, macrocytic. Most people presume that macrocytic anemia and megaloblastic anemia are the same thing. They're not. Macrocytic anemia means the cells are big. Megaloblastic anemia means there's impaired DNA synthesis. The way you tell the two apart is with a blood smear. Now, in real life, if there's an abnormality on the CBC, you'll get a reflexive blood smear. But on the test, you may actually have to order it. What you're looking for is hypersegmented neutrophils. That is, if you have 5 or more lobes on your PMNs, on your neutrophils, you have a megaloblastic anemia. Megaloblastic anemia implies impaired DNA synthesis and comes down to two diseases, B12 deficiency and folic acid deficiency. So you check a B12 and a folate. If your B12 is low, you have a B12 deficiency, and you replete B12. How you do that is a bit more complex and is in the macrocytic anemia lecture. If your folate is low, you have a folic acid deficiency, and you simply replete folate. If the values are equivocal, and you're not sure which one it is, but you've diagnosed megaloblastosis by 5 or more lobes on your neutrophils, you get the methylmalonic acid. The methylmalonic acid is elevated in B12. It is not elevated in folic acid deficiency. But back at that blood smear, if you said there were not hypersegmented neutrophils, you have a non-megaloblastic anemia. A non-megaloblastic anemia is going to come down to liver disease like cirrhosis, alcohol ingestion, some drugs that we'll get into, and then even rarer, some metabolic conditions. So the production anemias are going to have a low reticulocyte index and either a low MCV or a high MCV, and you know what the next step is. Normocytic anemia, the destruction variety, the kind that you're going to see most often, is either going to be hemolysis or hemorrhage. This is an acute drop in the hemoglobin. And what you use to separate hemolysis from hemorrhage is going to be the markers of hemolysis, LDH, haptoglobin, and bilirubin, both T-bili and D-bili. What you're looking for is an elevated LDH, a decreased haptoglobin, and an elevated T-bili. If that's positive, you've got hemolysis, and you will use a smear to help guide you. If those are negative, you've got hemorrhage, and you're going to find the hole. Plug it and give blood. Now, the exception to this is a normocytic anemia that is production. Normocytic anemias that have a low reticulocyte index imply one of two things. That is a marrow malignancy, like leukemia or myelodysplastic syndrome, or chronic kidney disease. So that if they have end-stage renal disease and they have a normocytic anemia and they're not bleeding, chances are it's chronic kidney disease. So I just want to say this again. You're not going to use the laboratories to separate hemolysis from hemorrhage. If it's hemorrhage, you're going to see them hemorrhaging. The labs will tell you this is hemolysis. If they don't have hemolytic labs and they're not bleeding, normocytic anemia is likely to be productive, and that is cancer and chronic kidney disease. That is the approach to anemia.